Thank you for joining the Circulus Spinal Cord Injury Primary Care Network webinar. Um, it's great to have you along. And so as most who've been here before the webinar, we usually will save questions till the end, but feel free to post things in the chat as well. But there'll be some discussion for Lakshmi at the end of things. I'm going to tell you a little bit. We're so pleased to have Lakshmi with us. I've known her for a couple of years, been involved in some of her master's work, but let me tell you a bit more about her. She is in the MD PhD program at Queen's University, and her research interests include quality improvement, medical education, and neurological rehabilitation, chronic disease management. She completed her Master's of Science in Health and Rehabilitation Science at Western in 2025. And the work that she's presenting today draws on the findings of her master's research. And so then building on this foundation, her doctoral work will examine how medical education can better support disability inclusive care. And Lakshmi's overarching goal is to translate research into practice changes that improve care and everyday health outcomes for people with disabilities. I can't tell you how important this kind of work is. It's so lacking, like when you look at the literature and just the practicalities of medical education, just how lacking it is that disability care is even a part of curriculum. So the work that she's going to be doing is just great. So with that, I'll turn it over to Lakshmi and thanks.
Correct. Okay, I will share my screen. Okay. All right, everything looks good. Perfect. Okay, well, hi everyone, and I just wanted to take some time to thank you for spending your lunch hour with me. And as mentioned, my name is Lakshmi. I'm super grateful to both Jamie and Katie for reaching out about this opportunity to share a bit about my master's work on cardiometabolic disease in primary care and specialized neurological rehabilitation. So to start, I thought it might be useful to take you along my educational and research journey that Jamie touched on a little bit. So I completed my Bachelor of Health Sciences at Western in 2024. And during my first year, I became involved as a research staff with the Research to Practice team under Dr. Dalton Wolf, who I'm sure many of you know of. And along that path, I was also introduced to Dr. Ali Bateman, a physiatrist at Parkwood Institute, who really adopted me into her growing research program on cardiometabolic disease. That's where this all started. Now, in 2024, once I completed my bachelor's, I was waitlisted for medical school and was stuck with not knowing where I was going to go next. And I decided to pursue a master's in health and rehabilitation sciences at Western to continue this program of research that we were developing in cardiometabolic disease. You'll come to see that we had a lot of ideas about where we could go next with our previous research, and we decided it'd be really worthwhile to pursue this in my gap year, per se. Come 2025, I defended my master's in May. I reapplied to medical school and was super lucky to get accepted to the MD PhD program here at Queen's, where I am right now. And I am currently supervised by Dr. Jennifer Tomasoni, who I'm sure many of you know of as well. All that to say, what I will be presenting is my master's work, as Jamie mentioned. And Jamie was actually on my advisory committee and was a really great support throughout this very time condensed process. So I'm really grateful for the opportunity to share the findings of our work with this network. So going back to a bit of background, what is cardiometabolic disease? Well, it's defined by clinical practice guidelines as the clustering of three or more conditions contributing to cardiovascular disease, diabetes mellitus, and or heart failure. And these conditions can include obesity, hypertension, dyslipidemia, and diabetes mellitus. Now, persons with neurological conditions such as spinal cord injury, multiple sclerosis, cerebral palsy, and spina bifida, they are at an increased risk of developing CMD. And the reasons for this are multifactorial. You have physiological changes such as autonomic nervous system dysfunction and inflammation, as well as barriers to leading a healthy lifestyle due to mobility challenges or accessibility. And similar to other chronic diseases, CMD also disproportionately affects those of lower socioeconomic status. And together, all of these kind of contribute to that level of increased risk. So as I mentioned, our program of research in cardiometabolic disease has started a long time ago. In my undergrad, Dr. Bateman and Dr. Wolf and I, we conducted a study exploring CMD risk in a sample of outpatients with spinal cord injury at Parkwood Institute. And the results were very striking. Almost every single patient that we sampled had at least one CMD risk factor. About three-fourths had at least two, and a little over two-fifths, sorry, had three or more risk factors, meaning that they officially met that clinical practice guideline criteria for having CMD. And we didn't stop there. We wanted to see whether or not screening was being done annually at the outpatient clinic at Parkwood Institute, as the guidelines pretty much indicate that risk is based on the time since the onset of injury. And when we did this, we found that screening rates were about the 10% mark, meaning there was a lot of room for improvement. We took a look at various barriers to screening, and Dr. Bateman actually conducted informal interviews with the staff and created this fishbone diagram to kind of represent those barriers. So the barriers kind of, oh, our slide is moving too fast, but our barriers kind of range from more systems level. So things like resources and funding for tools to organizational, so a lack of CMD prioritization, and also things about the clinic environment itself, whether it's inaccessible or having non-functional equipment. All of these kind of barriers contributed to not screening or intensifying treatment for CMD in patients with spinal cord injury. So after that, we had an understanding of what was going on at our site, but we wanted to explore some strategies out in the literature for CMD screening, diagnosis, and treatment specific to the spinal cord injury population. So we conducted a scoping review. So we searched the literature to see what was published. And we found that the most literature in this area pertained to diagnosing CMD. Several studies did explore therapeutic interventions, things like health promoting behaviors. So physical activity interventions, dietary interventions, behavior change, or a combination. And then also pharmacotherapy. There was a small subset as well. So now we had an issue where we had our first study, we looked at Parkwood. There was a high prevalence of CMD risk factors, but a lot of barriers to screening and treatment. And then we also did a scoping review where we found that most of the literature speaks to CMD diagnosis and not a lot of consideration of contextual factors. And this led us to think about, sites across Canada. What are they doing? What about the perspectives and roles of primary care providers? So far, we've only been exploring the role of physiatry. And what about other populations of neurological conditions? Persons with multiple sclerosis, cerebral palsy, spina bifida. So far, our focus had only been on spinal cord injury. And lastly, what are some barriers and facilitators that we can learn from different sites and specialties that maybe we could adapt and adopt at our own sites? And this led us to my master's work. And so we had three objectives. The first was to understand current knowledge, importance, confidence, and concern related to CMD management. We also wanted to understand current CMD practices within primary care and rehab settings. And then we also wanted to identify any areas for improvement in CMD care for persons with neurological conditions. So what did we do? We conducted a mixed method study in that we rolled out a survey, and then we also had one-on-one interviews combining both quantitative and qualitative research methods. All of the data was captured virtually, meaning that the survey was administered online and the interview was held on Zoom or Teams, depending on preference. As for who we sampled persons with spinal cord injury, multiple sclerosis, cerebral palsy, and spina bifida. And how we did this was through the Parkwood Institute outpatient clinics. We also sampled Ontario primary care providers, as well as physiatrists across Canada. And both of these recruitment initiatives were done through email invitations, really leveraging the networks of the study team in Dr. Wolf, Dr. Bateman, as well as JB. And recruitment and data collection occurred concurrently from December 1st, 2024 to February 26th, 2025. So the way that this worked was that as I was recruiting participants, I would launch the survey as well as follow up if they were willing to participate in the online interview so that there wasn't too much time in between. So diving a little bit deeper into the methods, what exactly did the online survey entail? So there were a set of demographic questions, so things like age, sex, gender, racial identity, partial postal code, years of practice, type of practice for the physicians, as well as condition-specific questions. We also had a 5-point Likert style question section that really hit home on evaluating knowledge, importance, confidence, and concern related to CMD management. So you can see here the scale goes from -2 for strongly disagree all the way to +2 for strongly agree. And lastly, we also had some multi-select questions related to resources that would be most beneficial in primary care and rehab settings. So in terms of the interview, once again, we wanted to understand knowledge, concern, importance, confidence related to CMD management. We wanted to unpack those survey answers a bit more. We also wanted to understand personal and environmental context for persons with neurological conditions. You might remember in our scoping review, we found that a lot of the literature just didn't really take an understanding to those contextual factors. And so we wanted to explore that a little bit more here. We also wanted to look at current CMD practices at clinics or rehab sites, and this was for the providers to gain an understanding of what was going on in other areas. And lastly, we wanted any target ideas or strategies for improvement in CMD care that hopefully we would be able to share and spark some ideas for those who read the paper and other knowledge products. So in terms of the results, I had 50 participants complete the online survey, 26 being persons with neurological conditions, 13 being primary care providers, and 11 being physiatrists. I conducted 19 interviews, 10 being with persons with neurological conditions, 3 being with primary care providers, and 6 being with physiatrists. So now taking a look at some of the demographic info, the majority of persons with neurological conditions were from urban areas, so about 68.2%. And the most frequently reported annual household income was less than 24,400. And this number is significant as it represents the Ontario annual household income cutoff based on a community size greater than 500,000. And essentially, this is a benchmark used to identify those considered as low income. Looking at the primary care providers now, the average age stratum was 30 to 39. PCPs also reported an average number of about 908 patients in their practice. And 69.2% of the PCPs that we sampled reported seeing less than 10 persons with neurological conditions in their practice. For the physiatrists, the most common age strata were 40 to 49 and 50 to 59. And we also recruited physiatrists from 5 provinces across Canada, the majority being from Ontario, but we were able to reach representation from British Columbia, Alberta, Saskatchewan, as well as New Brunswick. So now we're going to dive into the Likert style questions, looking at knowledge, importance, concern, confidence. And you can see here there are supports in rehab and supports in primary care. And those two metrics really ask the question of, are the resources and supports in rehab and primary care sufficient, or is there work to be done? And you can see this is a results for the patients. And you can see that CMD is important and it's a concern, but participants reported that they don't feel as though they have a lot of knowledge on the subject. And as well, we wanted to note that we did a sub-analysis here for urban versus rural, and the results were very similar to the overall sample. However, rural participants were more concerned about CMD, and I'm talking a very small fraction of the actual numbers, like we're talking 0.43 to 0.74. And they also had slightly less confidence in managing risk and making lifestyle changes. And even though the number or the numerical change is slim, we thought it would be really good to highlight that even in the sub-analysis, these differences were present. In terms of any materials or resources that these patients really highlighted, printed materials, individual education sessions were the top responses, but all options were rated highly. So things like goal setting exercises, group workshops, multimedia presentations were also highly regarded as well. So now looking at the primary care providers, you can see that all of the bars here lean right towards the agree and strongly agree sections. And here, the added change in our kind of criteria here is scope of care. So this was a question asking primary care providers if they feel as though CMD falls within their scope of care. And you can see that participants feel very strongly about the importance of CMD as well as the role that they play in CMD care. In terms of what resources primary care providers think would be most beneficial, they indicated individual education sessions for sure would be the top tier strategy, but that was followed up by printed materials, group workshops, etc. Once again, then this is consistent across all three participant groups that really any resource would be beneficial, not very specific to the format, but individual education sessions and printed materials were definitely the top responses. There was also a interesting free text note that a primary care provider left, and they suggested clear, bright summary sheets with a flow chart to guide clinical practice. And so this is more so of a resource from a bedside care perspective, but just something interesting to think about. And lastly, looking at the physiatrists, you can see there's a little bit of a spread with the disagree side and the agree side. And participants generally felt knowledgeable and recognized the importance of CMD, but the resources and supports in rehab are insufficient. And they also did not feel as strongly that CMD care fell within their scope of care. And in terms of the resources that physiatrists thought would be really beneficial, they thought printed materials and education sessions would be great. But once again, it was followed by goal setting, multimedia presentations, and group workshops. Other ideas that the physiatrists had included targeted resources to support people with neurological conditions who might be in lower resource settings, as well as online education modules and access to a health coach in an outpatient context. So now we're going to dive into the qualitative themes. And I'm really glad that we chose to do a mixed methods, quantitative and qualitative approach to this work. Not to say that the quantitative results don't have a story of their own, but I think in terms of what we were looking for to capture more of an experience and perspectives of the populations that we were sampling, I think it's really important that we did these interviews and got a little bit of a sense of why participants responded in certain ways. So the first qualitative theme relates to limitations to CMD care access and provision. And this relates to any barriers across micro, meso, and macro contexts that impact CMD care for persons with neurological conditions. And I was trying to think as I was creating this presentation, what would be a great way to present the qualitative findings. It's very text heavy, there's a lot of content, but I wanted to root our findings in the quotes of our participants. And so one of the sub-themes was related to multifaceted accessibility challenges. And you can see this participant quote here. I find with spina bifida, having that condition limits me in doing certain exercises. It bothers me to walk. I feel as if I can't do some of the things that otherwise, people can do. I think if I try to work on my physical health, I can better cope with the limitations of my condition. So all three groups, they noted barriers faced by persons with neurological conditions, and these range from transportation challenges, financial constraints, personal factors, physical limitations. Participants highlighted the unreliability of paratransit and taxi services, and many people with neurological conditions are also reliant on income and employment support, specifically through the Ontario Disability Support Program, or ODSP. And these participants also highlighted that the financial assistance that is provided through ODSP is often minimal and is insufficient to cover a lot of basic needs. Stress, trauma, barriers related to language and literacy and culture were also identified. Providers also mentioned the influence of cultural beliefs. So one participant expressed having challenges with providing Western healthcare services to those who identify as Indigenous due to mistrust. And that really just highlights a need for culturally competent care. And kind of relating back to the quote on the screen, due to fatigue, spasticity, pain, limited mobility, persons with neurological conditions, they expressed difficulty attending appointments or exercising consistently or maintaining a healthy diet due to all these factors, despite knowledge of those benefits. And participants did note some workarounds around this, such as exploring alternatives or exercising in increments, but still really hit home on the difficulty of it all. Another subtheme was related to the fragmentation of the healthcare system. And the quote here by a physiatrist is, "It's not a lack of knowledge, it's a lack of feet on the ground." And all three of the participant groups commented on the influence of the Canadian healthcare system. Both of the provider groups really hit home on the national shortage of primary care providers as a barrier to providing personalized attention to persons with neurological conditions in their practices. And due to the shortage, providers described having increased caseloads, which results in some time constraints during appointments, as well as prioritizing health concerns based on immediacy. Physiatrists also interestingly noted that because of the shortage, it's also led persons with neurological conditions to rely on them as their main point of contact for health concerns, as these individuals did not have a regular primary care provider. Interestingly, providers also expressed frustrations with being unable to consult disciplines about lab results, screening, referrals, or anything condition specific. It was really clear that current communication methods, things like paper and phone calls, were pretty insufficient. And persons with neurological conditions also expressed similar difficulties. There were long wait times in between appointments and referrals, and quite notably, providers across disciplines oftentimes lacked an understanding of disability in the context of chronic disease. And our last subtheme for this broader theme on limitations was related to limited staff uptake. So here's a quote here from a primary care provider. "Would I attend a talk at some place when it's only going to be applicable to one or two of my patients when I've got 300? And so providers really mentioned that despite knowledge of CMD and recognition of its importance, there is limited uptake in knowledge translation and practice change efforts. They noted that due to the low prevalence of persons with neurological conditions in their practices, there's generally less incentive and interest to seek out educational opportunities. Physiatrists also noted that without tangible cases or overt presentations of CMD, it's really difficult to convince other providers of its importance. So moving on to our second theme, which is related to facilitators to CMD access and provision. So in this theme, participants identified any facilitators that positively influence care, that enable providers and persons with neurological conditions to address CMD, not just from a clinical standpoint, but also from lifestyle management. And so the first kind of sub-theme or facilitator was about this e-consult system. And the quote here from a primary care provider, it says, "It's an e-consult system available across Ontario. You know, it's funny. I think it depends where you practice, how often people use these resources. I think in our area, it's quite high use, but I have friends who are family doctors in other communities, and I tell them about this and they're like, oh, they didn't know about it." So primary care providers, they explained this e-consult or e-referral system that has essentially increased their access to specialists for inquiring about patients in their care. They perceive that this system is underutilized due to a lack of knowledge of its existence. And they noted that usage is quite localized to providers in specific areas, really highlighting the need to bring awareness to the system across the province. Another sub-theme or facilitator was the value of having in-house services, resources, and expertise. And we have a quote here from a primary care provider as well. "We have many team members, often mental health workers or whoever, because people live in a system and there are many factors besides just a straightforward disease going on." So the provider groups really commented on the value of having an interdisciplinary team, a site champion, shared resources and expertise, all in which to support CMD care. Physiatrists noted that having a primary care provider embedded within their care team has supported knowledge and awareness of CMD. Primary care providers practicing in a family health team commented on having the value of allied health professionals within their team, people like dietitians, social workers, physiotherapists, occupational therapists, psychologists, being a part of the care team for referrals and consults. Having in-house services allows for more efficient care as it may facilitate timely interventions, can enhance conversation and communication between providers, and really ensure that persons with neurological conditions receive comprehensive support without all the mess of a delay. Primary care providers and physiatrists, they also commented on the value of having a site champion or someone who holds specific knowledge and expertise within their setting. Having this champion enables more timely resource and knowledge sharing and really contributes to increased awareness and reinforcement of CMD importance. Physiatrists also mentioned that having resources and experts in their broader community is a facilitator, through information sharing in lectures or presentations. And all groups really noted the value of connections with community partners for knowledge translation opportunities. The last sort of facilitator that was mentioned all had to do with the patient-provider relationship. And the quote here is from a physiatrist, and it says, the question is, what is going to motivate people to make changes that will optimize their health, which gives them greater capacity to participate in the things that are important and meaningful to them? So participants here, they really emphasize the importance of rapport and trust in fostering motivation and empowerment to take control of their own health. If a provider is really open to discourse, they demonstrate active engagement and they provide alternatives to treatment plans based on needs, this essentially increases confidence and motivation to adhere to such recommendations. As well, what was really interesting was that the patient-provider relationship also influenced comfort levels in discussing CMD-related concerns. So certain participants highlighted that the dynamic with their provider, whether it was a physiatrist or a primary care provider, that influenced who they wanted to oversee their CMD management and who they would discuss care plans or treatment options with. So really, it appears that prioritizing that relationship between the patient and the provider, really contributing to shared decision making, will contribute to a supportive environment that enhances aspects of self-management. Now looking at the third theme, this is all about enhancing CMD care through education, collaboration, and innovation. So participants, they noted opportunities to raise awareness, improve care coordination, and enhance CMD care delivery in both primary care and rehab settings. So the first sort of sub-theme was opportunities for physician education and exposure. And I really love this quote by a person with neurological condition. They say, a lot of this starts with the doctor's education. With established doctors, I'm not going to say it's too late, but it is. They might not be welcoming to it in terms of practice change, but they should be aware of this and should be informing patients of these illnesses about this condition. It should be embedded in their education before they become doctors. So all groups, they really did highlight a need for curriculum reform and continued education opportunities. Participants noted that introducing CMD early in medical education may help instill a proactive approach. It was also suggested to work with regulatory bodies or examination committees to make CMD care and as well as other chronic disease management that are very prevalent in specialized neurological populations, more of a certification requirement to hone in on its importance. Participants also highlighted that online resources or lectures could be great ways to share information. You could also incorporate keynote presentations on CMD care for high-risk populations at well-known conferences, and that could also serve as another avenue for knowledge translation. Finding ways to encourage attendance was a tricky part, and so one suggestion was to maybe have a keynote presentation where it is the only thing being scheduled during a certain time slot during a conference, and also collaborating with community partners that might also enhance engagement and broaden the reach of this work. Participants also spoke about the development of resources, and we touched on this before with the different types like printed materials and modules and whatever, but essentially the type of resource doesn't quite matter. It's just that it is needed. And so handouts and other resources can really empower persons with neurological conditions to bring up CMD with their providers and foster that self-advocacy and active participation in their care. Notably, and what I thought was really interesting doing this work was the participants made a point to talk about the timing in which the resources are provided. and how it's really critical to avoid information overload. So providing a lot of resources after a diagnosis was said to be a little bit overwhelming, whereas kind of a staged approach allows for a more gradual reinforcement of CMD management over time. Participants also talked about peer support and how important it is for fostering encouragement, motivation, exchanging strategies, as well as collaborating on problem solving. And an interdisciplinary approach to some sort of group programming was recommended. So, not just having physicians, physiotherapists, occupational therapists lead these things, but also incorporating persons with lived experience to jointly take part in this education. Another big sub-theme here was about expanding roles in the interdisciplinary team, as well as strengthening information exchange. So we have a quote here by a physiatrist who says, "We've got a massive gap in rehabilitative care to not have librarians who are information navigators as part of the team. They have incredible resource, but they are highly underutilized." And so providers are talking here about expanding roles, whether that's adding additional staff or expanding the responsibilities of existing team members. So there was one suggestion to have nurse practitioners kind of act as a patient navigator in that they are the intermediary between the physiatrist and the primary care provider. As well, another idea was to have an internist who has specific knowledge and expertise on chronic disease management, or, as this quote speaks to, a medical librarian to facilitate information sharing and be a very timely resource. Institutional support is obviously very much needed for these things, and there's a lot of financial constraints with hiring and expanding roles, but these were ideas that were floated by the participants to see if there were opportunities to improve. In terms of information exchange, we heard earlier that current methods for communication were pretty subpar, but one suggestion was to maybe hold brief meetings to identify key needs and establish kind of a structured communication plan at the outset. Another strategy was to enhance the electronic medical record systems to better support clinical decision making, whether that's incorporating cues, flags for screening or follow-ups, as well as embedding some accessible resources to reduce barriers to limited information access. And the last sub-theme here is about establishing community partnerships. And so this quote here says, "I would love to see every community center have accessible equipment. If we could require that in every community center, every college and post-secondary institution, I think that would make a huge difference." And this was something that was also expressed by all groups. They emphasized the importance of building strong partnerships, not only with academic institutions, but also community organizations to really raise awareness for CMD care. Collaborating with institutions could also drive research such as this and produce data that could reinforce the urgency of addressing CMD in these populations. You could also leverage the specialized equipment that some of these institutions have. One participant noted, the use of calorimetry devices, which may kind of foster more comprehensive screenings and provide deeper insights. And participants, they really just highlighted the value of community centers and making them accessible, expanding access for physical activity opportunities to really enable persons with neurological conditions to adopt and maintain healthier lifestyles. Looking at the last theme here, and this was all about the importance of CMD and the various knowledge pathways in which people were made aware of it. So persons with neurological conditions, they expressed a desire to take a more active role in reducing the risk of CMD, whether that was through lifestyle intervention or seeking out care services. And so this is a quote from a person with neurological condition. They said, "I've always thought that one of the problems with modern medicine as we know it is the act of self-advocacy." And so for persons with neurological conditions, their knowledge of CMD generally was attributed to family history, genetic linkages, and familial experiences. That's what heightened their concern about it. So if they had a family member who had a cardiovascular event or experienced something of that sort, they were made more aware of that being a problem. And they really expressed the need to be well informed before their healthcare appointments to self-advocate for their concerns. Self-advocacy appears to motivate them to seek out external information, ensuring that they are really prepared to speak with providers. While physiatrists and primary care providers and other specialists, they make up the core components of the care team. Persons with neurological conditions, they noted that it was up to them to be proactive in making healthy lifestyle choices. And although it wasn't explicitly named in the interviews, I had a sense that they might have been referring to the concept of self-management and really just taking more active responsibility for their health and well-being. They also noted the importance of finding methods of staying active and leading a healthy lifestyle that align with their personal preferences to increase their motivation beyond just having that knowledge that physical activity is really good for you. And so here is another quote from a participant saying, I have a whole team around me. So in that way, I'm not doing it myself, but I'm the captain of that ship. I'm not always successful, but I'm trying to be proactive with it related to CMD management. And this quote kind of goes back to the concept of persons with neurological conditions are in a team of healthcare providers, but they are the captain of that ship. And this is kind of getting a sense of them taking ownership of their care. So now looking at the primary care providers and the physiatrists, it was really interesting that their existing knowledge came from clinical experiences, site-specific expertise and resources, independent learning and information seeking. Those were kind of the three main focus points. Looking at what physiatrists think about in terms of their role in CMD management, they view their role as educators. So they acknowledge their expertise in neurological populations, as well as their knowledge of lifestyle recommendations. But they do note that chronic disease management, long-term management, align more with the practice of a primary care provider. Primary care providers, they also agreed that CMD management falls under primary care. However, both respondents, they really opted for a combined approach with physiatrists. And this joint approach could look like physiatrists providing awareness or flagging an issue to the primary care provider, while also being available for any questions or concerns. It was really interesting to learn about the different practices that were happening across Canada. And there was definitely some variation. In some cases, the physiatrists act as the educators, and education and empowerment are the key focus. The goal is to provide information to make lifestyle changes and seek appropriate care from the primary care providers. In other areas, physiatrists actually take on CMD screening. And in other areas, some mentioned their method is strictly a referral to other specialists or a lack of review entirely and kind of relying on the primary care provider to address it. In terms of the primary care providers, it seems as though that CMD screening is definitely something that is occurring regularly and in accordance with clinical practice guidelines. Primary care providers really highlighted lifestyle intervention as a main kind of recommendation to all persons with neurological conditions, regardless of age. And they highlighted that while pharmacotherapy might not be routinely recommended for younger populations, it is intentionally discussed earlier for the reason being that these persons do have a neurological condition. So there was a lot. There's a lot of information that came from this study and a lot of fruitful resources and facilitators and barriers that I'm really hopeful will help change the landscape of CMD management, both in rehab settings and primary care. And so it's really hard to put all these findings together and think about a way to frame it all. But I thought I would once again frame my findings through a participant quote. And I really love this quote. I think it's very, very powerful. And it's information power liberates you to make critical decisions. And we know that information power, it can come in different forms. It can come in the form of evidence. So when you think about my scoping review or my other undergraduate study, looking at CMD risk, looking at what's out there in the literature, this might help inform other approaches to CMD care. Maybe a multi-pronged approach is better, or maybe therapeutic interventions might develop and be kind of the problem, solving the problem. It could also come from developing resources and education opportunities. So for patients, maybe this is more so about empowering them to um, take control over their own health and promote self-advocacy. And then for providers, maybe it's to inform bedside care, or maybe it is also education about how disability intersects with chronic disease management. And lastly, information power can come from sharing what works and scaling it across the country. Through this research, I learned a lot about facilitators and barriers specific to different settings. And I do think that they have the potential to be implemented elsewhere after they're adopted and adapted into different contexts. So you might be wondering, now what? So I've completed my master's and I've moved on to my PhD. And once again, I'm going to frame the slide using a participant's quote. A lot of this starts with the doctor's education. And this quote really did stick with me. And as Jamie mentioned in the start of this presentation, there is definitely a growing amount of literature on how physicians and medical students may not feel adequately prepared to care for persons with disabilities, as well the role of medical education in shaping conceptualizations of disability. And so caring for persons with disabilities, it's not just limited to primary care and physiatry. I think it was Jamie himself who told me that every specialty can expect a person with disability in their practice. And, that really does call for increased knowledge as well as awareness. So I'm shifting gears to medical education in my PhD, and I'm really excited to work in partnership with the School of Medicine here at Queen's University. And conversations are still flowing. I have a bunch of meetings with the curriculum team and those developers in the next coming weeks, but this is essentially what we aim to do in my dissertation and the work to come. I want to develop a sort of framework for disability inclusion in undergraduate medical education. I want to analyze the Queen's University medical curriculum for disability inclusion. And my research is very timely in that the Queen's University School of Medicine is currently undergoing curriculum renewal. So it's a really prime opportunity to work alongside them in partnership and see where we can add these elements to better prepare future physicians. Which leads me to my sort of last objective or study, which is to evaluate medical student outcomes before and after curriculum renewal. And hopefully, we will be able to see a positive change in the way that disability is conceptualized among medical students, but also in the preparedness and awareness that these students have in being able to take care of persons with disabilities in their future practices. And so that is all that I have to present to you today. And I just wanted to thank you once again for taking your hour to listen. I did want to share some special acknowledgements here to my co-supervisors, as well as those on my advisory committee, people who share their expertise with me. Of course, the study participants and the Parkwood Institute outpatient clinic staff for their support with recruitment. As well, thank you, Jamie and Katie, again for the opportunity to present to this network. And I've left my email here, but maybe I can also drop it in the chat. If you have any questions beyond our discussion today, feel free to contact whenever. Thank you.
Lakshmi, thanks so much. That was an excellent presentation. I'm going to open it up to the group. I have a couple questions in that, but I want to open it up to others. Craig, do you want to start off there?
Yeah, I was just wondering, you talked about allied health professionals. Have you looked possibly at using kinesiology graduates, at least filling some of the gaps as a low-cost solution versus like a nurse practitioner or a physician?
Yeah, that is a great question. And one of the limitations I think of this study is that we did explore physiatry and primary care and didn't think about what other allied health professionals might also bring to the table with their knowledge. We know that rehab and primary care is very interdisciplinary, and so kinesiologists would be a really great opportunity, as particularly in their growing role in physiotherapy gyms, in hospital settings. That could be a really great avenue to facilitate really fast information sharing. And you're right, would be definitely a lower cost alternative to maybe hiring a nurse practitioner or a less strenuous option than expanding a role that's been very clearly predetermined. So definitely a great point and something to consider.
Thanks, Craig. Anybody else?
Yeah, I thought that was a great talk. Thank you very much. I was struck by the comment about you have to focus on, early learners or medical students because those who are out already, maybe it's too late for them. Anyway, and I think that's great that you're working on that with regards to your PhD. Just with regards to the education of, medical practitioners, the interprofessional team, and as well patients themselves. I wonder if you've have any opinions with regards to artificial intelligence, because in practice, AI is coming into prominence with clinicians, and the first generation really is just transcription, but some of the next generation is actually trying to put in um, evidence-informed decision making into the AI programs. And this would be an example of something that I wonder whether it could be embedded in something there, and whether you had some thoughts in that regard. Just interested in
Yeah.
your thought.
Yeah, and you're absolutely right. AI is definitely a very hot topic in medicine, and I feel like in any response to anything AI, you got to think about obviously ethical concerns, and it's really what you're inputting it that really affects the output. And so it's interesting because one of the suggestions was to adapt the electronic medical record system to make it more intuitive for providers to whether they need bedside information or they want to share accessible resources. So, yeah, maybe AI could be an interesting avenue to explore, with the caveat being that there needs to be some safeguards and some vetoing of what's actually being inputted in terms of the information. But if that is a way to more accessibly streamline the information sharing or resource sharing with patients or with clinicians, I think that could definitely be an interesting avenue to explore.
It's
Thanks.
interesting. I'll just maybe dovetail onto that because I was thinking sort of the same thing there, Joe, that, in this age of just so much information that we can't keep up with.
Hmm.
And, Lakshmi, I think we talked about it initially with sort of your master's work, and at the same time is that, you know, our education in primary care is based on guidelines and everything that are really just for the able-bodied population. They never take into account sort of anything outside of that. So if you think about cholesterol guidelines and that, hypertension guidelines, all these things on cardiometabolic disease do not take into account the differences in the disability population, in particular spinal cord injury, which is quite different in terms of how we're suggesting that maybe we would screen earlier. There's different BMI cutoffs. There's all these things that just nobody has any awareness, and that is definitely something that AI has the potential to really leverage, right? To just bring that
Hmm.
into, if within your EMR you had the identifying data and the conditions that the patient has, it would automatically alert you to some of these things that you would otherwise have no idea that you're 25 30-year-old with spinal cord injury. You should start thinking about lipid screening and all that kind of stuff. So
Hmm.
yeah, I think that's an interesting opportunity. Before I go into Taposhi's comment or question in the chat, I also just want to say, you brought up some great things here, Lakshmi, in this. I really love the fact that primary care sees it as a rule to do this, because we should. I'd be alarmed if we weren't. So that's awesome. And it goes along with other studies. It also goes along with the fact that, physiatry specialists often find, there's this tension because they find they have to do this stuff,
Hmm.
but they don't feel comfortable doing it. So, at the end, you talk about this communication, and that is so, so important between the specialties. And then I also love that you bring in this, this perspective of the persons with lived experience, right? Because they, from a self-management potential or self-management idea, but also to try to have these discussions with physicians, which has been highlighted in your research that that's not an easy thing to do. So then we take it back to where people are trained early on to sort of have this reception to this kind of thing. I just think it's wonderful. This isn't a question here. This is just a wonderful approach to all these, like kind of like a three-pronged sort of approach of increasing awareness and how you get some of this done. Just really well done. My one question, though, I did want to ask before I go to Taposi's, I ramble on here, is I also love that you had these separate conditions here, but they are different. But I love that you have them in there because it broadens the awareness of everything, especially within primary care. Within this study, what did you have the opportunity to talk to any people who were MS sort of specialty neurologists that way, anything like that run MS clinics and their feelings on the cardiometabolic disease? I'd be interested in how they're kind of approaching it, because I think probably most of it was sort of spinal cord injured physiatrists, if I'm not mistaken, right?
Yeah, you're absolutely right. The most frequently encountered neurological population in the physiatrist was spinal cord injury. And it's interesting. I had a subset of physiatrists who specialize in cerebral palsy and spina bifida. And then Dr. Bateman herself runs a MS clinic, and obviously she wasn't a participant of the study, but she was the one who really advocated to broaden our population reach, thinking about how other conditions really are influenced by this and may have similar experiences across the board in terms of what resources and opportunities they need to learn about CMD. And it was interesting with the physiatrists who specialize in CP and SB in that they felt less aware of CMD. They didn't have as much knowledge. And even though in my quantitative results, I think in the physiatrist section, if I go here, like knowledge is positive. It is generally agreed upon. But when you look at the specific disciplines or in terms of what populations they look at, it does vary a lot by context and their education. And so it is definitely interesting to report on how even the neurological population that you are specialized in can have variances in your awareness and knowledge of CMD. And kind of looping back to your earlier comment, and thank you so much for your kind words with that. I remember when I was heading into my MD PhD and pitching an idea of what to do. And I was really headstrong on doing some sort of intervention, like a physical activity intervention to see if that would support persons with neurological conditions with CMD risk. And while I definitely think that that's important work and something that would further the field, I spoke to Jen, and we were thinking more about the upstream kind of problem here and how we can have a bigger reach on medical students and future physicians to become a little bit more aware of disability, but also how chronic disease intersects with disability, and just knowing the fact that every student and every future physician will eventually have a person with disability in their practice. Just because they're a one-off doesn't mean that they should be tossed aside in terms of education and awareness. So really excited to pursue that work and other opportunities that spew out from this.
I'm just going to read you Taposhi's question in the chat as well.
Perfect.
So he was saying, I was wondering if rural persons with disabilities and primary care providers experience greater lack of education and resources compared to urban, and what could be some solution other than community partnerships?
Yeah, so we were very fortunate in that we did have enough data for partial postal codes to actually do that sub-analysis of urban versus rural. Unfortunately, that wasn't feasible for a lot of the other demographic factors, which is why I didn't really present it here. But yeah, the rural participants who had disabilities, they generally had less knowledge, but they were more concerned about CMD. So they knew it was a problem, but they had less resources to kind of help manage or cope with it. And I think one of the physiatrists in their free text response in the survey mentioned that one opportunity for improvement could be to have specialized resources or education specifically for lower resource communities, and really having them be a targeted population now that we've identified that they are at essentially an increased risk, to really hone in on working with those populations and trying to figure out ways to promote that education. In terms of strategies, I always come from like approach of we should ask the community first what they would like to see in terms of just not just imposing something, some sort of educational module or whatever, but rather taking the time to build a partnership. This work was done in London, Ontario, and I'm, working with the rural communities in those surrounding areas, I think would be a good start. Maybe a community of practice, trying to figure out what are the opportunities for improvement that these participants identify, and then go from there and kind of co-creating an approach. So that would be kind of my first step pitch.
Thank you. Any other questions? Well, Lakshmi, thank you again for taking time out of your super busy schedule. Excellent presentation. Love the work you're going to be doing. Yeah, just thank you. And thanks for everybody for participating today.
Yeah, thank you so much for having me. And I'm excited to see where this research goes and excited to keep up with the rest of the webinars.
Thanks, everybody. Have a good day.